Okay, our today's topic is drugs used to treat hypertension, and this is the first part. So, first of all, lecture objectives. At the end of this lecture, you must be able to understand the term of hypertension, what are the different types of hypertension, and what are the factors which are responsible for the adjustment of blood pressure. This is very important, right? What are the factors responsible for the adjustment of blood pressure? And explain the drugs strategy to control blood pressure. What are the different plans? What are the different mechanisms by which we can reduce the blood pressure, control the blood pressure? What are the different classes of drugs that can be used to control blood pressure? Explain the role of diuretics in the treatment of blood pressure, and describe the role of drugs influencing sympathetic nerves. So basically, today we are going to discuss two major group, and in the second lecture, the rest of the others or remaining blood group we will discuss. So arterial blood pressure basically is determined by the cardiac output and peripheral resistance. And this is important. Sometimes peripheral resistance is not increased, but if the cardiac output is increased, that will lead to increased blood pressure. So one of the if mechanism is involved or increase, so it will raise the blood pressure. And you know the cardiac output, and when the contractility of the heart is increased, that will lead to increased cardiac output, right? And peripheral resistance, you know, if the vessels are normally dilated, it's very important concept. When the blood is ejected from the left ventricle into the aorta, that means aorta is going to receive the blood. When the contraction, when the systolic phase is there, when the left ventricle is contracted, blood will enter into the aorta. But if the constriction is there, that means aorta is not going to receive the blood pressure, so it will exert a pressure, right? So this is important. Now hypertension, what are the types? There are types: essential hypertension, that is labeled as the primary hypertension, or secondary hypertension. 90 to 95% in most of the patient with persistent hypertension, right, in which there is no specific cause, right? Genesis of hypertension is unknown, but there are some predisposing factors that we will think about. Okay, maybe due to this primary hypertension, right? So susceptible obesity, this is one of the factors that can lead to increased blood pressure. Stress, salt intake, lack of magnesium, potassium, calcium, ethanol increased dose, and smoking, right? And non-susceptible, like positive family history, insulin resistance, age, sex, defect of local vasomotoric regulation. What is secondary hypertension? Secondary hypertension means increased blood pressure is due to or secondary to some distinct disease, like renal and renovascular disease. If there is a problem related to arterial stenosis, hormonal defects in which we have Cushing syndrome, pheochromocytoma, mechanical defect, coarctation of hypertension in pregnancy, and drug-induced hypertension, like sympathetomimetic drugs. This is one of the important example. You know, sympathetomimetic drug means adrenergic agonist, the drugs which are responsible to stimulate adrenergic receptors, right? And for black adrenergic receptor, alpha 1 adrenergic receptors and beta 1 adrenergic receptors. Alpha 1 adrenergic receptors predominantly on vessels, and beta 1 adrenergic receptor predominantly on heart. Other example of drug, glucocorticoids, and these are the two key examples. And sometimes some neurological diseases are responsible to increase the blood pressure. Receptors, they are responsible for rapid adjustment in blood pressure. That means whether if pressure receptors are stimulated and try or normalize blood pressure. And if there is hypotension or decreased blood pressure, again these baroreceptors stimulated and try to increase the blood pressure. Kidney, this is very important, plays a key role in long-term control of blood pressure and is the pathogenesis of hypertension. Very important, renin is one of the important substances which is released from the kidney. Excretion of salt and water controls intravascular volume, which influences the force of contraction of the heart by Starling mechanism. Secretion of renin, 1/3 of the patient, increases production of angiotensin II, right? This angiotensin causes direct constriction of resistance vessels and stimulation of aldosterone synthesis in the adrenal cortex. So, adrenal cortex, which is responsible to release aldosterone, is responsible to increase the absorption of sodium. This is important. Responsible to enhance the reabsorption of sodium. And where the sodium goes, water will automatically move along with sodium, along with this solute, right? So increased sodium reabsorption is enhanced due to aldosterone secretion, and water will move automatically along with sodium. So what will happen? Increase water and salt reabsorption. So that will lead to increased blood volume, and increased blood volume will exert a pressure, right? So this is very important mechanism. That means there are some drugs, if they are going to inhibit the release of renin, we can inhibit the activity of angiotensin II. And when there is no angiotensin II activity, we can prevent the constriction and we can prevent the activity of aldosterone. So when we inhibit the activity of aldosterone, there will be no reabsorption of salt and water. So this is how we can avoid the reabsorption of salt and water. So we can avoid the high blood volume that can occur due to reabsorption of salt and water. Renal disease like vascular, parenchymal, or obstructive is a cause of arterial hypertension. Now, what are the drug strategies? Before discussing this drug strategies, so different points we have discussed. What are those points? So that in hypertension, involvement of cardiac output and peripheral resistance plays a key volume, right? So one of the drug that can decrease the total peripheral resistance, right? So this is one of the mechanism by which we can reduce the blood pressure. Second mechanism, and how we can reduce the peripheral resistance by producing vasodilatation, because due to vasoconstriction, peripheral resistance is increased. Okay, how we can decrease the cardiac output? by reducing the contractility of the heart. If we slow down the heart activity, so what will happen? Decrease amount of blood is ejected, so we can reduce the cardiac output, so we can reduce the blood pressure. And the third mechanism, by decreasing body fluid volume. And how we can decrease the body fluid volume, the key group that we can use is labeled as the diuretics. You know, diuretics are the drugs which enhances the excretion of water in urine, right? So this is how we can the blood volume. Decreased blood pressure may result in homeostatic regulation. This is important. Okay, when we have achieved the task, we have reduced the blood pressure. But one of the point that already we have discussed, baroreceptor reflex. So when the blood pressure is reduced, autonomic activity is going to be activated in response to this decreased blood pressure with the help of baroreceptor. So reflexly, they try to again increase the blood pressure due to decreased blood pressure response, right? And reflex, that is why the word is reflex in response to decreased blood pressure. So reflex tachycardia due to increased sympathetic activity to compensate, to counterbalance this low blood pressure activity. And the second is the edema, right? Because increased renin activity is responsible to what? Because when we suppress the activity, decrease blood pressure, our kidney is when the due to decreased blood pressure, less amount of blood will reaches the kidney. So kidney will think that, okay, there is low blood pressure. So how I can overcome this problem? So this is the automatic regulatory mechanism. So in response to decreased blood pressure, renin from the macula densa is released to compensate this decreased blood pressure, right? So renin is released and it will convert angiotensinogen. You know, angiotensinogen is synthesized in the liver. This angiotensinogen is converted into angiotensin 1 with the help of this renin. And angiotensin 1 is converted into angiotensin 2 with the help of angiotensin converting enzyme, right? And in the initial slides, we have discussed this angiotensin 2 basically is responsible to promote or induce vasoconstriction, which is responsible to raise the blood pressure. And number 2, it activates the activity of aldosterone, which is responsible to enhance the reabsorption of sodium, and water will move along with sodium. So it is responsible to increase the reabsorption of salt and water. So increase blood volume. So it will lead to edema. It will lead to edema. The choice of antihypertensive drug. Now, these are the different groups. So the choice of antihypertensive drug will depend on the relevant indications or contraindications for the individual patient, right? So in the previous slide, there are different drug strategies that already we have discussed. One of the group may be responsible to decrease the peripheral resistance by producing vasodilatation. There are some drugs that are responsible to decrease the cardiac activity. There are some drugs which are labeled as diuretic that enhances the excretion of salt and water, right? So this is how we can reduce the blood volume, right? So these are the different mechanisms. The choice of antihypertensive drug will depend on the relevant indications or contraindications for the individual patient. So one of the group for mild to moderate hypertension, we can use the diuretics. It's a big group. You know, there are different sub groups or classification of diuretics like thiazide diuretic, loop diuretic, potassium sparing diuretic, and carbonic anhydrase inhibitors, right? So osmotic diuretics. But for the mild to moderate hypertension, which group we use to control blood pressure? Thiazide diuretics. This is important point. There are different groups of diuretics, but for the mild to moderate hypertension, we generally use preferably which group of diuretic? Thiazide diuretic, right? But in severe hypertension, we can use a powerful diuretic group that is labeled as the loop diuretics. But generally for mild to moderate hypertension, we prefer to use which diuretic? Thiazide diuretic. Second group, drugs influencing sympathetic nerves. It's a very important group. You know, the sympathetic nervous system, that is also called adrenergic nervous systems, and at the nerve terminals, you know, the basic neurotransmitter at the nerve terminals which are responsible to induce the sympathetic activity or to stimulate the adrenergic receptors is norepinephrine, right? So epinephrine, norepinephrine, both are neurotransmitters which are responsible to produce activity in adrenergic nervous system, and there are other neurotransmitter that is also responsible to stimulate sympathetic activity, that is the dopamine, right? Dopamine and dopamine, right? When we say stimulation of sympathetic activity, basically we are talking about the stimulation of adrenergic receptors. And in adrenergic receptors, we have alpha-1 receptors, we have alpha-2 receptors, we have beta-1 receptors, we have beta-2 receptors. And if we just try to recall the autonomic nervous system, you know, when stimulation of alpha-1 receptors and predominantly alpha-1 receptors are located on vessels or heart. Predominantly alpha-1 receptors are located on heart or vessels. Anyone? Anyone tell me the answer? Predominantly alpha-1 receptors are located on heart or vessels. Vessels, very good, vessels, right? So what will happen? You know, when stimulation of alpha-1 receptor, it will produce vasoconstriction. So what will happen due to vasoconstriction? It will lead to increased peripheral resistance. So increased peripheral resistance will lead to what? It will increase the venous return. It will increase the venous return. When increased amount of blood will enter into the heart, so heart will produce its extra activity, right? So it will lead to increased cardiac output, right? This is how stimulation of alpha-1 receptor is responsible to increase the blood pressure. Increase vasoconstriction is responsible to increase the peripheral resistance. Increased peripheral resistance is responsible to increase the venous return. So increased amount of blood will enter into the blood, so it will exert a pressure. So increased amount of blood is pumped out, so increase cardiac output. So increase amount of blood, when it will enter in the blood vessel, it will exert a pressure, so it will lead to hypertension. So is there any clinical importance of this mechanism, this vasoconstriction mechanism? One of the important clinical correlation, and we must know this important concept. So what is the importance? You know, this stimulation of alpha 1 receptor, it's very important because the stimulation of these receptor is responsible to prevent the orthostatic hypotension. And if there is a change in the posture, let me explain it. If there is a change in the exposure, for example, from the sitting position, if anyone is going to stand in a standing position, you know what will happen? Due to gravity, blood will move towards downward, right? So what will happen? What will happen? There is a compromise in the blood flow in the head or in the cerebral vessels. So what will happen? It may induce the syncope, right? So normally it doesn't happen. Why? When there is a change in the posture, so when there is a change, right, from, for example, from the sitting position, I am into standing position. So this downward movement of blood flow is prevented to avoid the syncope by stimulation of alpha 1 receptor. So vessel is constricted and it prevents the downward movement of blood. So this is how it controls the postural hypotension. The third group is the vasodilators. This point also we have discussed. Increased peripheral resistance is due to vasoconstriction phenomena that will lead to increased peripheral resistance. So if we use the drugs that can relaxes the vessels, smooth muscles, so this is how we can decreases the peripheral resistance. So what will happen? Due to dilatation, decrease venous return, because when there is a dilatation, there is cooling of blood. So decrease venous return, decrease cardiac output, right? One thing you must remember, right? So there is automatic regulatory mechanism. If we reduces the blood flow, automatically the counter mechanism is going to start. When there is decreased blood pressure, so reflex tachycardia due to stimulation of increased sympathetic activity to enhance the cardiac activity. Second mechanism, when there is decreased blood pressure, so decreased amount of blood volume will reaches the kidney. So kidney will think, okay, there is a problem. The proper blood volume is not coming, so it will releases the renin. So renin, angiotensin, aldosterone system is going to be activated, and it tries to increase the blood volume to compensate this hypertension, right? So this important point you must remember. The angiotensin converting enzyme inhibitors or angiotensin receptor blockers. But today we will discuss the two important groups, diuretic and drugs influencing sympathetic nerves. Diuretics drugs are first choice for treating patients with mild to moderate hypertension, often combined with another drug in treatment of more severe hypertension. Examples of thiazide diuretics: hydrochlorothiazide, lopamide, chlorthalidone, indapamide, and metipamine. But commonly, clinically, we generally use the hydrochlorothiazide. Preferable to loop diuretics for the treatment of uncomplicated hypertension. Given by mouth as a single morning dose, begin to act within 1 to 2 hours and work for 12 to 24 hours. Treatment should be started using a lower dose. So how? You know, when the when the blood is filtered through the glomerulus, you know, salt and water is also filtered, electrolytes, right? So if we, this is very interesting, some normally salts are again reabsorbed. And we know when there is reabsorption of solute like sodium, so it will catches water. So water will also move from the lumen into the blood. So it will increase the blood volume. So if we inhibit this reabsorption, right? And what is the site of action? Distal convoluted tubule. This is another point that is asked in BCQ. Thiazide diuretics acts on which part of nephron? You know, the Bowman capsule, proximal convoluted tubule, descending loop of Henle, ascending loop of Henle, distal convoluted tubule, collecting ducts. Okay. So this thiazide diuretic that acts on distal convoluted tubule and it prevents the reabsorption of sodium and chloride ion. So what will happen? The concentration of solute will increase in the lumen. So what will happen? So, you know, water molecule moves from low solute concentration to high solute concentration. So this, when we inhibit the reabsorption of sodium and chloride ion, these solutes are accumulated in the lumen. So increase the amount of solute. So it will catches water from inside to outside. And so the water and salt, they are going to be squeezed out. So this is how we can reduce the body fluid volume. Mechanism of action: lower blood pressure by reduction of blood volume and by direct vascular effects. So not only decrease the blood volume by this mechanism like inhibit, and this is the main mechanism, inhibit the reabsorption of sodium and chloride, and so it will raise the solute concentration in the lumen and water will move from inside to outside towards this high solute concentration, and so the solute and as well as water is going to be squeezed out. But it may also directly dilate the blood vessels. Inhibition of sodium chloride transport in the early segment of distal convoluted tubule. Natriuresis, that means enhances the excretion of sodium. Decrease in preload and cardiac output. This is the renal effect. Slow decrease of total peripheral resistance raised initially during chronic treatment, suggesting an action on resistant vessels. This is the extrarenal effects, right? So the main effect is the renal effect of this diuretics when it inhibits the reabsorption of sodium and chloride, and so increase solute concentration in the lumen. It will catches water from inside to outside, but it can also this is the extra renal or additional activity of thiazide diuretic. Adverse effects. These are important from the BCQ point of view or from the Viva point of view, when it will enhances the excretion of solute or electrolytes. So what will happen? Increased amount is going to be squeezed out, so it may lead to hyponatremia, because when increased amount of sodium is going to be squeezed out, so decreased sodium can be present in the blood. That is called the hyponatremia. Hypokalemia combined with potassium sparing diuretic, it may cause hypokalemia. It will also increases the excretion of potassium. Hypomagnesemia, hyperuricemia, right? Hyperuricemia. Why? Because most diuretic reduce the urate clearance. Because this diuretic uses the transport mechanism, that uric acid, the transport mechanism which is present in the tubule, so it can interfere the urate clearance, urate secretion into the lumen, because these drugs may act or producing activity by using that pump, right? Hyperglycemia, hypercalcemia, this is important point. This is important point, hypercalcemia, because there is another diuretic and that is supposed to be the most powerful diuretic, that is the loop diuretic. It will causes hypocalcemia, right? But thiazide diuretic will causes hypercalcemia. Why or how? Thiazide reduce urinary calcium ion clearance. So it will precipitate clinically significant hypercalcemia in hypertensive patient with hyperparathyroidism. And one of the important point, this is one of the important clinical correlating point, and I have seen one of the question in USMLE exam tool book that one of the female having the history of osteoporosis, and the physician wanted to start the therapy with the diuretic. So which one of the following diuretic can be used to control blood pressure in this female patient having osteoporosis? So in that situation, we select a drug from the thiazide group because in osteoporosis there is deficiency of calcium. So this group would be helpful specifically in this patient, not only control the blood pressure, but also raises the level of calcium. Hypercholesterolemia, a small increase in plasma cholesterol concentration. Loop diuretics, the key example and commonly used loop diuretic in our clinical setup is the furosemide. Other examples are torsemide, ethacronic acid, useful in hypertensive patient with moderate or severe renal impairment or in patient with hypertensive heart failure. Relatively short acting, diuresis occur over the 4 hours following a dose. Used in hypertension if response to thiazide is inadequate. Mechanism of action, they inhibit, and as the name is indicated, the site of action would be. Now there are different segments. This is important point that you must know. You know, when we say loop of Henle, descending loop of Henle, ascending loop of Henle, right? So on which part basically it acts? The ascending loop of Henle. Okay, there is a reply. Let me check it. Thick ascending loop of Henle. Very good. Thick, because descending loop of Henle, then there is a thin segment, and again the upper portion is the thick segment, right? So ascending thick segment of the loop of Henle, right? They inhibit the co-transport of sodium, potassium, and chloride. If we compare with thiazide diuretic, the thiazide diuretic, they inhibit the reabsorption of sodium and chloride, but loop diuretic, they inhibit the transportation of sodium, potassium, and chloride. Increase calcium and magnesium excretion. Okay, you know, when we compare the side effects, hyponatremia, hypokalemia, hypomagnesemia, same in thiazide diuretic as well as loop diuretic. One of the key difference that you must know, and this is the exam oriented point that I have already focused, that is related to calcium, right? So thiazide diuretic inhibit the excretion of calcium, or in another way you can say it enhances the reabsorption of calcium. So ultimately it will increases the blood level of calcium. But loop diuretics enhances the excretion of calcium as well, right? So that is why I have already mentioned one of the important point, clinical correlation, and this is a question that can be asked if a patient having a history of osteoporosis, right? So which diuretic we can prefer? That is the thiazide diuretic, right? They have useful pulmonary vasodilating effect. The mechanism is not clear, but it is responsible to reduce the pulmonary hypertension. Now this is The mechanism of action, this already we have discussed, the thick ascending limb of lobe of Henle. Toxicity, hypokalemia, just like in thiazide diuretic, right? Autotoxicity, this is important because the loop diuretics, they are sulfur containing compound. So the drug, if suppose a patient is taking multiple drug or different drug regime for different comorbidities, so we'll have to be very, very careful. For example, this loop diuretic may cause autotoxicity, but fortunately reversible. So you must think, okay, is there any other drug that is also responsible to produce autotoxicity? So it will produce the marked autotoxicity. So this we must know. So we try to avoid the combination of different drugs that have the same problem related to this autotoxicity. And one of the major example is the one of the group of antibiotic, that is the aminoglycoside, that can cause autotoxicity, right? So we'll have to be very, very careful if a patient is on aminoglycoside group of antibiotic, right? So gentamicin, okay, this gentamicin that is related to aminoglycoside group. Okay, decrease of magnesium plasma concentration, hypomagnesemia, that is just like the thiazide diuretic. Hyperuricemia, because competition with uric acid about tubular secretion, this already we have discussed. This is the same with just like thiazide diuretic. Sulfonamide allergy, this point already we have discussed. The loop diuretic, sulfur containing compound. So this is the journal mechanism. If a patient having a sulfur allergy or sulfonamide allergy, it is better to avoid the use of these drugs in that patient, because it's a powerful, supposed to be the powerful diuretic, increased chances of dehydration. So that is why we do not use, because there is a point that comes into your mind, if this is supposed to be the most powerful diuretic, so then why generally we use thiazide diuretic commonly? Because in mild to moderate hypertension, there is no marked excretion, so it's not going to cause increase fluid loss, so it will not cause dehydration. But because the loop diuretic is responsible to enhance the excretion or increase amount of volume is going to be squeezed out, so it may cause the dehydration. So that is why its use is restricted in emergency situation. Now the second group, drug influencing sympathetic nerves. So already the important points I have shared with you related to adrenergic receptors, important concept related to alpha-1 receptor, agonist activity that is responsible to produce vasoconstriction, right? So alpha adrenoceptor antagonist. Now you can understand easily that it will lead to produce vasoconstriction, increase peripheral resistance, increase venous return, increase cardiac output, and it will lead to increased blood pressure. So if we block this receptor, more specifically alpha-1 receptor, so there is vasodilatation, there is cooling of blood, decreased venous return, decreased cardiac output, right? But one important point already we have discussed. If we are using adrenoceptor blockers or adrenoceptor antagonists, one problem can occur. So I'm giving the hint. If alpha-1 receptor antagonist is recommended, we suggest that it is better to give the therapy at bedtime, at night time. Why? Why? If a patient is taking alpha adrenoceptor antagonist, it is better to administer the drug at bedtime to avoid which problem? Okay, there is a reply. So good. Ortho is to avoid the orthostatic hypotension. Very nice. To avoid the orthostatic hypotension. Because at bedtime, that patient is going to take the medicine and there is no change in the posture that can cause the postural hypotension. Very good. So mechanism of action, when we block this alpha-1 receptor, so there is no vasoconstriction, rather it will produce vasodilatation, so reduce vascular resistance and decrease blood pressure by antagonizing or clonic action of noradrenaline on alpha-1 receptor. Competitive with a short-term action, we have two alpha receptors, alpha-1 or alpha-2. And this is the general term, this is the general concept. If a drug is specifically bind with this specific receptor that is called the non-selective. So generally we are required to block the alpha-1 receptors. Generally we are required the selective alpha-1 receptor blockers, right? So short-term action, non-selective, alpha non-selective, what does it mean? That means this phentolamine block both alpha-1 or alpha-2. Alpha-1 selective, that is prazosin, and this is one of the drugs that is being used commonly. Diuretics, so these are the selective alpha-1 blocker. Long-acting drugs, alpha-1 antagonist, we have doxazosin and terazosin, right? So these are also selective alpha-1 selective blockers, but having a long action, right? Non-competitive with long-term action, non-selective, that is the example of phenoxybenzamine. That means, what does it mean? Non-competitive and non-competitive. That means we can, suppose prazosin is bind with receptor. We can displace this prazosin if we give the high doses of alpha-1 agonist, right? And non-competitive means when the drug is bind with the receptor, this binding is permanent. This binding is irreversible, right? So this is called the non-competitive. When the drug is going to be squeezed out from the body and the new receptors are going to be generated, then we can resume the activity of that receptor. Toxicity, the main manifestations are drowsiness, weakness, and this very important. And already we have discussed orthostatic hypotension. First dose, bedtime administration is recommended to avoid the syncope, to avoid the dropping of blood pressure. And for the non-selective agents, reflex tachycardia. Reflex tachycardia in patient with coronary disease, angina may be precipitated by the tachycardia, less frequent in selective alpha-1 blockers. Now, why, if we use the non-selective alpha blockers, so why the increased chances of reflex tachycardia? Because when we say non-selective antagonists, what does it mean? Not only block alpha-1 receptor, but also block alpha-2 receptor. Now tell me, what is the importance of what will happen if we block the alpha-2 receptors? So, first of all, you must know the normal activity of alpha-2 receptors. Then we would be able to compare the antagonistic activity. Alpha-2 receptors, they are generally inhibiting receptors, and they are located presynaptically. For example, norepinephrine is released from the nerve terminals. It will bind with the postsynaptic receptors like alpha-1 receptors and beta-1 receptors, and not only bind with postsynaptic receptors, but also this norepinephrine also bind with this presynaptic alpha-2 receptor. Why? to regulate the release of norepinephrine, to avoid the exaggerated activity, to avoid the overactivity. Because norepinephrine, some of the molecule bind with postsynaptic receptors and induces the alpha 1 receptor or beta 1 receptors. But some of the norepinephrine also bind with presynaptic alpha 2 receptor. When there is a stimulation, blocking of alpha 2 receptor, first we discuss the agonist activity, right? So norepinephrine is released. This we are discussing the normal phenomena, right? So when norepinephrine is released from the nerve terminal, it will bind with postsynaptic receptors, right? Stimulate the alpha 1 receptor, beta 1 receptor, right? And stimulate the cardiac activity. And some of the norepinephrine molecule also bind with alpha 2 receptors, which are located presynaptically, right? And this stimulation of alpha 2 receptors, you know, what it will cause? It will inhibit the further release of norepinephrine. It will inhibit the further release of norepinephrine. So now we discuss the antagonistic activity. Okay, we are using non-selective alpha blockers. Okay, by blocking alpha 1 receptor, we produces the vasodilatation, so decreases the peripheral resistance. Okay, it will decrease the blood pressure. And when we block alpha 2 receptor, so what will happen? There is no feedback control of norepinephrine release. Norepinephrine will release persistently and it will stimulate the cardiac activity, right? And it will cause the increased chances of reflex tachycardia, right? So this is the explanation of this. There is a question, sir, presynaptic causes decrease the norepinephrine. Yes, this already we have discussed. This is the normal phenomena. This is the feedback mechanism for control, maintain the control activity. Norepinephrine is released, so some of the molecule bind with the postsynaptic receptor to stimulate the cardiac activity, and some of the molecules also bind with alpha 2 receptors which are located presynaptically to control the further release of norepinephrine to avoid the exaggerated activity. When we block this receptor, so there is no feedback control activity, so increase release of norepinephrine, so it will further activate the cardiac activity. So this is the explanation of this phenomenon. Now this beta adrenoceptor antagonist, because you know when we say cardiovascular system, in blood pressure, involvement of heart as well as involvement of vessels. So we have discussed the drug that can control the vessel activity. Now we control the cardiac activity because predominantly this point already I have told you, I have discussed with you, predominantly on heart, beta 1 receptors are located. When beta 1 receptors are stimulated, it will increase the cardiac activity by increasing contractility, by increasing heart rate, right? And one of the important, another activity of beta 1 receptor stimulation is the increased release of renin, right? So beta 1 block receptors resulting fall in cardiac output, decrease blood pressure, and they reduce the renin secretion, right? Because in the initial slide, we have discussed renin is responsible to activate renin, angiotensin, aldosterone system. Because renin is responsible to convert angiotensinogen to angiotensin 1, angiotensin One is converted with the help of angiotensin converting enzyme into angiotensin 2. Angiotensin 2 is responsible to induce vasoconstriction as well as induce the aldosterone activity, and aldosterone is responsible to enhance the reabsorption of sodium, and water will move toward sodium movement. So this is how we can increase the blood volume, and increased blood volume is responsible to increase the blood pressure. Now again, just like alpha receptors, we have selective beta 1 receptor antagonists as well as non-selective, right? So when we say cardioselective, so more specifically, which group should come into our mind? That is the beta 1 blockers. And key examples, the key drugs which are being used commonly in our clinical setup, two important examples are atenolol and metoprolol. And beta 1 blocker with intrinsic sympathetic activity. What does it mean? That means these drugs not only block beta receptor but also some stimulation, right? So partial agonist activity. An example is acebutolol. And there are some drugs that selectively block beta 1 and alpha 1. This is very interesting, bro. And cardiovascular control, right? So, the vessels are responsible to increase blood pressure as well as increase cardiac activity is responsible for blood pressure. So we have drugs available that can block both beta as well as alpha 1 receptor blockers. And very important example is labetalol. And this is one of the important that can be used in emergency situation, in hypertensive emergencies, this labetalol, right? So there is another drug that is carvedilol that having both blocking activity, beta 1 receptor as well as alpha 1 blocker activity. And this carvedilol is generally used in heart failure patient. Cardio non-selective, that means it block, non-selective means block not only beta 1 but also beta 2. As far as the blood pressure control is concerned, we are controlling blood pressure. So if we block beta 1 receptor, that would be sufficient. But there are some drugs, okay, when we use that drug, it will control the blood pressure by blocking beta 1 receptor. But this beta 2 receptor blocking activity is unnecessary, unrequired. So sometimes it may cause some side effects. Examples are metoprolol, propranolol, atenolol, and the key example is the propranolol. This is one of the prototype drug of this beta blockers. Now, important point which is asked in the exam, right? There is a question: why non-selective beta blockers should be avoided in a patient having a history of asthma? Why non-selective beta blockers should be avoided in a patient having a history of asthma? Anyone? Okay, there is a answer: bronchoconstriction. Okay, let me explain it. Normally beta 2 receptor stimulation is responsible to produce bronchodilation, right? So when we block this receptor, the opposite effect, it will cause bronchoconstriction. Very good. Okay, there is another clinical point that could be asked in the exam. In a patient having a history of diabetes, we have to be very, very careful if we are using non-selective beta blockers. So these two questions are very important clinical correlation. Now, anyone tell me why, if a patient is a diabetic patient, we have to be very, very careful. If a patient is diabetic, definitely that patient is on anti-diabetic drug, An anti-diabetic drug, the main mechanism, the purpose of using an anti-diabetic drug is to reduce the blood sugar level, right? So why? If a patient is on anti-diabetic drug or if a patient having history of diabetes, we have to be very, very careful if we are using non-selective beta blockers in diabetic patient. Anyone? Anyone? No one? I will have to explain. Okay. So, again, stimulation of beta 1 receptor is responsible to induce the process of glycogenolysis. And the glycogenolysis process is responsible to increase the blood sugar level. And it also stimulates the secretion of glucagon, that is also responsible to increase the blood glucose level. This is the normal mechanism. When we block this beta 2 receptor, the opposite effect, we are going to decrease the blood level by stopping process of glycogenolysis, by stopping release of glucagon. So use of beta blockers can produce hypoglycemia. So already I have discussed this important point. If a patient is diabetic, definitely that patient is on anti-diabetic drug, and the purpose of anti-diabetic drug is to produce the hypoglycemic state. So this beta blocker will also produce the hypoglycemia. So it may cause marked hypoglycemic activity. And sometimes it will mask the true hypoglycemic activity due to anti-diabetic drug, right? So we don't know whether this hypoglycemic activity is due to beta blocker or itself from the anti-diabetic drug. So that is why we'll have to be very, very careful. Now the beta 1 and beta 2 blockers with intrinsic sympathetomimetic activity or partial agonist activity, pindolol and bopindolol. So this partial agonist activity or intrinsic sympathetomimetic activity may be an advantage in treating patient with asthma because these drugs will cause bronchodilation as well. They have moderate effect on lipid metabolism, causes lesser vasospasm and negative inotropic effect, right? So basically these drugs can avoid that reflex activity, right? Reflex activity. Adverse effects, cardiovascular adverse effects, which are extension of the beta blocking activity, like when it will slow down the heart rate, it will cause pericardia, arterioventricular blockage due to decreased conduction, congestive heart failure, unstable asthmatic attack in patient with airway disease, premonitory symptoms of hypoglycemia, right, from insulin overdosage, and CNS adverse effects, sedation, fatigue, and sleep alteration. These one already we have discussed. The last group of this drug influencing sympathetic nerves, centrally acting drugs. And already we have discussed the concept. Centrally acting drugs, because in the Bible, this is one of the questions, what are the centrally acting drugs? So you will say methyl dopa and clonidine. What is the mechanism of action? Centrally acting drugs producing its activity by inducing or stimulating alpha 2 receptors. And this already we have discussed. Alpha 2 receptors normally are inhibitory receptor producing inhibitory activity, and they are located presynaptically. So when they will stimulate these receptors, what will happen? It will stop the further release of norepinephrine. So this is how we can reduce the cardiac activity. Okay. So, but limited use in the treatment of hypertension. But this methyl dopa, one of the common example, like one of the commonly given drug, aldomade, which is methyl dopa, hypertension during pregnancy. Methyl Dopa causes symptoms of drowsiness and fatigue that are intolerable to many adult patients in long-term use. They are seldom used to treat essential hypertension. Clonidine is potent but poorly tolerated because it may cause rebound hypertension if it is discontinued abruptly. Is an uncommon but severe problem can occur. Clonidine can be used in opioid withdrawal symptoms to control the opioid withdrawal symptoms. So this is one of the important point related to this clonidine. So this is all about the drugs or the first part of the drugs used in the treatment of hypertension. So in the coming lecture, inshallah, we will discuss the remaining two important group of drugs like vasodilators and angiotensin converting enzyme inhibitor or angiotensin receptor blockers. Okay, so I think this is all about for today. So inshallah, in the next lecture, we will continue with the remaining group. So there is a question, can you again explain postural hypertension and how it causes? So, postural hypertension, normally, suppose I am in a sitting position. When we become in a standing position, my blood pressure should drop. Why? Because, when I am in a standing position, due to gravity, the movement of blood flow towards the earth, right? So it will drop the blood pressure. But normally it doesn't happen. Why? Because when there is a change in the posture, alpha-1 receptors are stimulated and it will cause the vasoconstriction. So this vasoconstriction prevent the dropping of blood, so prevent the postural hypertension, prevent the orthostatic hypertension, right? But when we block these receptors, so there is a chance of postural hypertension. Okay? Okay, thank you so much. Okay, sir, can you please explain the non-selective alpha-1 blockers works in diabetes? So what do you want? Okay, again, inhibitory activity. So if we are using non-selective, when we say non-selective, that means not only block alpha-1 but also block alpha-2. Normally, alpha-2 receptor stimulation inhibit the release of insulin, right? Inhibit the release of insulin. When we block these receptors, so increase release of insulin. So increase insulin